You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome to part 2 of our talk on anti-inflammatory therapies for asthma with Dr. Njira Lugogo. I'm your host, Dr. Amy Attaway. In case you missed our first episode, today's guest, Dr. Lugogo, is a clinical professor of medicine and director of the University of Michigan Asthma Program. We'll be talking about some of the barriers to treatment for anti-inflammatory therapies in asthma, such as insurance coverage, and also about advocacy, and then we'll dive into her research career. I think also some other barriers, maybe getting insurance. I think that's one of the things. Yeah,
when something is new, it's always like that.
Yeah.
But you have to engage in advocacy. So we've partnered with Blue Cross Blue Shield of Michigan. We're doing this QI initiative in the state. We have about 800 participating providers and 18 physician organizations, both independent and employed physicians. And so what we did early on before, we had ICS albuterol on the market, is we met with them and we presented the case that we should be covering 2, formoterol containing inhalers a month for people who needed to be on maintenance and reliever therapy. And, we talked to them, we presented the data, and we argued the case, and they changed their formulary to allow 2 inhalers a month for people who needed it. Mm-hmm. And Michigan Medicaid also covers it. So I think as clinicians, we underestimate our impact. Our health plans want to save money also. Mm-hmm. And so, they want their patients to do well. They want to save money. Those ED visits and hospitalizations are very costly because, the patients ultimately go and get all kinds of scans, stem to stern, a lot of, very expensive testing. And so, it behooves us to really partner with them and say, hey, these are some really very strong evidence-based strategies to help these kinds of patients. Now that we have, albuterol and budesonide, initially it had just come to market. The Batura study hadn't been published, which was published this year. So now we have an idea that, okay, this drug helps reduce exacerbation, so much so that they had to stop the study early because the impact on those patients was so significant in terms of exacerbation reduction. So I think it's time to go back and have conversations. I know the company provides coupons to allow people with commercial insurance to get it a little bit cheaper. We have been successful in prior authorizations, describing the need and explaining why it's necessary. And I think we need to now start partnering with some of our our insurance companies and Medicaid and really advocate for this therapy as a way of reducing healthcare resource utilization. When you spend $85 billion to treat people with asthma and 10 people still a day are dying and people's outcomes are not improving, the number of ER visits didn't change, we're doing something wrong and we really need to change that. In terms of education to patients, I've found patients to be very receptive. I will tell you, many of them have no idea that asthma is inflammation and constriction. They don't know anything about smooth muscle or anything about what the disease is. And when you educate them about it, they really comprehend that and they are more accepting of this treatment paradigm. And so far, people have found it useful, both maintenance and reliever therapy with formoterol and this new ICS budesonide therapy. They find it really helpful. They come back and say, wow, I feel like it helps me more. And then, for providers, we've been trying, we got a grant. We created a webinar. We are going to record the webinar. We've given it live. I'm going to give a grand rounds tomorrow. We are going to record this webinar on anti-inflammatory reliever, the science behind it, the practical implications, and we're going to publish that. We've done some things within our health system to flag when someone is prescribing a SABA. Hey, there's new information out there saying that there are better strategies, and we have a smart set that makes it very easy to order anti-inflammatory reliever therapy. And so that's some work my colleague Dr. Mohan has been doing, and we've seen those prescriptions going down. And as a matter of fact, people used to give an albuterol with 12 refills. And, if you take 11 refills in a year and you're really taking that medicine, your risk of dying is 31 times higher. So we just need to point that out to our providers. And so we've seen a reduction, and we are continuing to educate providers, including launching a maintenance of certification opportunity for people to do a small QI project in their clinics to figure out how to tackle some things on a system level, like maybe a best practice advisory flag, or figuring out who's on SABA monotherapy and targeting those people first, particularly those with a healthcare resource utilization visit. So I think there are all these kinds of strategies. We just need to keep banging the drums and showing up everywhere, and talking to everybody ad nauseum, and hopefully we'll see a change. And I feel like we've seen a huge change just in the last year, a year and a half, where people are really like, oh wow, this is makes so much sense, and we see that they're embracing this much more readily.
Mm-hmm. Well, I have to, that was one of the things, like, think about how far asthma has come
Yeah.
in just the last 5-10 years. So,
Yes.
so exciting. And I love that you're like, we identified a problem, and, you highlighted advocacy and how we can make that change, which is just amazing to hear from you. So, and then
Thank you.
finally, so we wanted to also kind of hear if you could give us a little bit of a story about your journey, and how, because you're such a successful, top of your field provider and clinician, master clinician. How did it's not, and I think a lot of early career investigators kind of wonder what the path was, because it's often not a straight path. So do you want to talk a little bit about, she's shaking her head in case anyone's wondering, but do you want to talk a little bit about that and kind of what brought you to where you are right now?
Yeah, so I will start out by saying that I was drawn to pulmonary because of critical care.
Hmm.
And so I think that's a common theme for a lot of people. As a medical student, you really don't see that much pulmonary, you don't know that much about it. And so when I was finishing medical school, I went into internal medicine. I would say still you get more inpatient exposure and a little clinic exposure, but unless you seek it out, you really don't get a ton of subspecialty clinic exposure. And I think our cardiology colleagues are much better at enticing people to do cardiology. And so when I was training, I sort of said, well, I'll do pulmonary, but I love the ICU. It was so exciting to me, like the acute changes in physiology, the immediate feedback, and patients are getting better, and you just really get hooked on it. And so I went into pulmonary for critical care. And then I wanted to do clinical research. And I thought, well, I want to learn some clinical research skills. I'm not sure how to do that quite easily in the ICU. And I looked around. I was at Duke as a fellow at the time, and Monica Kraft had just come to open the asthma center, and she had moved from National Jewish to Durham. And I thought, well, she knows how to do clinical research, so I'll just learn everything I can about clinical research. And I was quite naive because I was like, then I'll just use my clinical research skills and do ICU research, which was quite interesting. And I was like, asthma, kind of like okay, but how interesting can it really be? You give people inhalers, like in the ICU, it's so fun.
Yeah, yeah.
And so I start going to the asthma clinic, and then I'm like, wow, what is this? It was very nuanced. It was really complex. I love patients, and I like this longitudinal care. I was very happy in my primary care practice. I just didn't want to do primary care, but I loved that longitudinal aspect. And I'll be honest with you, a lot of the asthma patients looked like me. They were people who came from a variety of backgrounds, and some people who are like in their 30s and 40s, and and you started to identify with this journey. And as you saw, the more refractory patients, that was back in the early 2000s. We had omalizumab. We weren't using it quite as much. There were OCS dependent patients, and they were being ravaged by asthma, and we were over there trying to figure out whether to try methotrexate or Cellcept, or what do you do. And I spent some time working with Monica. We were on these large networks. I was part of the ACRN studies and the AsthmaNet studies. And we did translational research. So we would do bronchoscopies on patients and take the samples to the lab. And I became very humbled by that experience because, I remember one day doing a procedure. We did an experiment, and it was a Western blot. And then at the very last minute, you go into the dark room to prepare your Western blot to see the bands so you can figure out how much protein there is. I believe that's what Western blots are for. So there you go. That's how bad I was in the.
We still do them. I do like 5 a day.
Okay, there you go. So I'm standing there in the dark room. I turn the light on, and there are no bands. And I remember standing there, and I was like, I see people who are dying. Like, oh my gosh, why can't I get a Western blot to work? And my epithelial cells would die, and it was very humbling. But I learned something very, very important. That I wasn't very good in the lab. Well, that was sometimes you need to learn what you can and can't do. But I learned the value of translational science and understanding mechanisms of disease, and really bringing that back from the bench to the bedside. So I would say that's one thing. The second thing is I participated in clinical research studies, not so many pharma, but like NIH-funded clinical trials and networks. So in the networks, I learned the value of being part of a team and in a collaborative atmosphere, and learning from colleagues and seeing how people think about complex problems and try to solve them. And then the third thing that I learned early on is I never wanted to feel helpless. In fact, I think that's a trait I've had all through my life, is I just don't like the feeling of helplessness. And so I realized that I didn't want to be the person who had to tell the patient that I didn't know what to do. I didn't have anything to do or offer. And that drove my passion towards finding answers and doing clinical trials, because I could always tell the patient, hey, we're working on a new solution. Like, maybe I don't have one right now, but we have this study that we are doing, or this is the pipeline of future development. And so I will say that my road was a bit windy. It was, fits and starts. It was always in asthma. So, I feel like if you wind within a certain band, you might eventually straighten the line a little bit. If you're doing, research in 10 different areas, it becomes a little bit too much. I coupled my passion for clinical care in asthma with a passion for finding answers to treat patients with asthma. And then, I learned to say no. I'm still very terrible at saying no, but at least I say yes to things that have to do with asthma. And I had to, at some point, start to make some decisions about giving things up. So, right before COVID, I gave up ICU care, which was a big cross the road for me, because you always feel like, oh my gosh, I honed this skill, but then I realized maybe I won't have the breadth, I just have the depth. And so right now I tell people I'm not a very good pulmonary doctor, I'm probably not the best ICU doctor, but I'm a very good asthma doctor. And so I sort of have narrowed my band. I still wind a little bit, but within a smaller margin. I've coupled passion with focus. Maybe first start with passion and then hone it in and maybe get a little focus over time, increase your depth as you go. And, you just eventually will find your way. And I've said yes to some crazy ideas along the way that have panned out. So, that's really where I would say you should go. And I'll give more advice after you ask me some additional questions. But I have some thoughts about future potential opportunities in this area for young people who might be listening to this podcast.
When you become a member of our global American Thoracic Society community of more than 30,000 healthcare providers and researchers, you'll have access to cutting-edge science through ATS journals and publications, discounts on the annual ATS International Conference, CME, and ATS Ed Plus products, and a robust, collaborative online medical community of peers in our ATS Doc Matter community. Join today at thoracic.org/join.
Oh, that's great. No, I think I'd just say like passion and focus. And then, but that's the end, right? Like it started out, you tried things that you didn't think you were going to like. So you have to like put yourself out there, be uncomfortable, do something that you never thought you were going to do, because we all have these ideas in our head and they're probably completely different, like 10 years down the road than what we were thinking. So, but what I think additional advice would you say?
Yeah, well, I would say that, a career in clinical trials is actually really, really fun. I'm going to tell you that, there were some challenges. Sometimes when you're the person doing pharma trials, in an academic setting, particularly, people may not look at that as a special skill set. If you're doing basic or translational research or you're NIH funded, there's clearly universal respect for that. People are like, wow, you got NIH funding, that's serious. That's somebody who's really contributing on a high level. When you're doing pharma trials, there's a presumption that it's not a special skill set. Anybody can do it. You just follow a protocol, so forth. And I will say there are like a spectrum of ways to engage in this work. When I started out, I just wanted to be a really good site PI. And I was energetic. I looked at the protocol and I gave the companies feedback and said, well, this looks like a challenge and this thing is a problem and I'm worried about this inclusion. I was just really very engaged. Initially, I would sort of say, well, why am I not on publications, for example? But I had a poor understanding of how that happens. So if you're a very successful site PI, sometimes you can get on publications that way. But a lot of times the people getting on publications are people who've been there since the beginning, developing the protocol, serving on scientific advisory committees. They are following the execution of the trial. They're looking at the study results, and then they're participating in publications. So when you start out, I think you need to real focus on becoming a really good PI, engaging with these companies, giving advice and insights that only you have, given that you're the one actually executing the protocol. So then over time, I started getting asked to participate in advisory meetings, and I would sit in the room and wonder why I was there. I had that imposter syndrome, like, I shouldn't be sitting here next to these people. Like, I read their papers, they do everything. Why am I sitting here? But, I spoke up. I just gave my ideas and my clinical, they have the ability to create the drugs. They don't take care of patients. So you give that invaluable insights into what's happening on the street and how patients are receiving this, how you're incorporating these new treatments, what are the unanswered questions for you as a clinician. And then next thing you know, I was invited to some scientific committees where they were saying, hey, we have this new drug, we want to design a trial. And I'm like, wow, this is so exciting. And so I got to contribute there. And now in the last few years, I've become privileged enough to become the international coordinating investigator for some of the international studies. For example, the inhaled TSLP studies going on right now. And so I think, that was a 10 or more year process. So you should be patient. You need to be somebody who's comfortable being uncomfortable, as you said, Amy, because you are inherently a business person. Your earning money and you're paying staff and you're managing them, and you need to be savvy about, the money. It's not as comfortable. Getting an NIH grant is very hard, but once you have it, there's a little more security. Like, I get this much money each year for 5 years if I do what I said I was going to do. On the other hand, I'm earning every dollar. Like, every visit I do generates revenue. I have to account for the revenue, figure out if I'm covering my staff. I have to, know how to budget. And so those are skills you need to learn, the financial oversight over your research business. And that's something, of course, I'm always willing to educate people on. And then, just you make a difference. You're able to be there. I use drugs. I can say, hey, I used tezepelumab before it was available because I did the phase 3 study. Then there was an open label study, and okay, I didn't have a ton of patients, but I get a lot of experience with this. I get to be in the know. I really love being in the know, knowing the data results before they're published and things like that makes me feel really excited. And now in my latter years, I'm not that old, but I'm transitioning more towards like, okay, what do I want to spend the last few years doing? And, I figured out I don't want to manage faculty. I love my colleagues. I love all the pulmonologists out there, but I don't want to be a division chief managing other faculty. I want to understand implementation science. I didn't start out there. And when I was asked to do this state QI program, I had no QI credentials, but I had passion and knowledge, and I felt like I can figure it out. I can bring in experts that know how to do QI work, and I want to learn how to implement change because, I've spent 15 years discovering drugs which then aren't being used, and the patient outcomes are not changing. So how do we bridge this gap? And so now I'm very much more interested in educating other providers and figuring out how to exact change and help people to embrace new treatment paradigms. And so I think that's where my focus is shifting to, continuing with clinical trials, but more on a high level, empowering my mentees to become site PIs, and then focusing more on, developing new clinical trials, answering questions, and helping companies think through that critically, but then focusing on implementation. So embrace the journey. It's a good career choice to have. I've managed to get promoted doing this kind of work. And so, there is a path for people who are really passionate about clinical research.
That's great. I love embracing the journey and realizing that the person you are when you start, I think, is different than the person you are,
Yes.
throughout your life. So of course it's going to change. Your path is going to change because you've changed. I think
Yes.
that's one of my takeaways from that. So yeah.
Absolutely. You just have to listen to your gut too, because you will be asked to do certain things when you get to a certain level. And for example, with the issue of administrative work, I've done administrative work. I ran an asthma center. I run our clinical research unit here at University of Michigan. I've done a lot of administrative work, but I had to really be, truthful with myself, similarly to with the ICU, give or take, is this, I can do this, but is it where I want to be? And is my passion really? And I think going back to passion and what drives you and being focused, and then sort of like, narrowing the band and sort of going forth, I think is like the best way to be successful. And then, tapping into other people that are experts, reaching out. I've gotten to this point because of all the people, both in the US and internationally, that I looked up to. I sat in rooms with, I picked their brains, I learned how they think, and I just sort of developed my own unique way of thinking and doing things. But it's been a product of so much input from so many people that, I still admire to this day and still get to work with very closely. And lastly, I personally believe that you should never get too drunk on your own hype. You should always remain humble. And anytime people ask me to do things, I feel privileged. I'm like, thank you so much for asking me. You could have asked anybody else, and you came to me, and I appreciate that. And I've never lost that childlike wonder, from being in those rooms in the first place and saying, oh my gosh, what am I doing here? I still have that similar feeling, except now I'm not sort of like, oh my gosh, what am I doing here? Because these people know way more than I do. But it's, oh my gosh, you could have asked anybody and you still feel like my voice is important. And so I really am so grateful for those opportunities. And now I'm turning around and trying to lift up other, more junior faculty and advocate for them and get them to be in the room so that they too can have those moments of, oh my gosh, what am I doing here? And then grow to become much more experienced and successful.
That's wonderful. So I think humility, staying curious, paying it forward, these are never bad things. So thank you.
Yes, absolutely.
Well, we have taken up a lot of your time and we have really enjoyed it. But I think all good things have to come to an end. So we just want to thank you again, Dr. Lugogo, for giving all this amazing insights into anti-inflammatory rescue therapy and then your stellar career and the path you took. So thank you again for joining us on the podcast.
Oh, thank you so much for having me. I'm hoping that maybe we'll inspire a few people to do clinical trials. We really need more people. So
great. They will. I'll have them all reach out to you. So
thank you so much.
All right. Thank you so much.
You're welcome.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.